I apologise, I've got a bit of a croaky voice. I've got a cold, which I attribute to one of my grandchildren. I never thought I'd be the token non-bearded male in a series of presentations. You never know. I'd also like to acknowledge the traditional owners of the land we're meeting on, the Gadigal people of the Eora Nation, and pay my respects to their elders past and present, and acknowledge the significant health burden that they experience. So I'm going to be talking about a survey that we did last year, which was a survey conducted by the special interest group of an organisation called the Primary Care Research Group, which is a North American group but is a kind of peak primary care research body in the US, although some people in the UK would dispute that. Sorry, in the world. And acknowledge that this was conducted by colleagues in Canada, the US and Ireland. The aim was to assess how interpretation is being provided, funded and governed in primary care practices, serving refugees in the four of the countries where refugees are resettled. Just a very quick little bit of background. This is a complicated table, but the bottom line, the bottom row is the important one, that really there are differences between the countries. In Canada, there's interpreters are accredited and trained. Access to funding varies between each province. Those of you who know Canada know that, and as far as the health system is concerned, they've got a health system in each province, which is different from one province to another. And there's no national free phone interpreting, although there were some phone interpreter services. In Ireland, much more limited access to face-to-face and phone interpreting, and it varies a lot across Ireland, and there was actually no accredited training program for interpreters in Ireland at this time. I don't know whether there's been subsequent to the beginning of last year, but it certainly wasn't the beginning of last year. And in the US, again, a lot of variation from state to state. Healthcare facilities usually provide interpreters. Some states require Medicaid to pay for interpreters for medical visits. So there is quite a lot of subsidisation of interpreting in the US, particularly for refugees, which was the focus of this. So the methods were, this is a cross-sectional study, an online survey. We sought to determine some of the practice characteristics and the characteristics of the patient populations that the respondents were serving, the level of interpreter use, impacts and barriers, and we conducted both qualitative and quantitative analysis on some of the survey. And the participants were a fairly select group of people who were engaged in providing care to refugees. In Ireland, the sample is a little bit different. Actually, and that reflects the response rate. It was actually sent more broadly to almost all GPs in Ireland, and so the response rate was quite a lot lower in Ireland. Most respondents were female and aged between 40 to 59 years of age, which is not dissimilar to most of general practice in Australia. And respondents have been in practice for an average of 20 years and have cared for refugees for an average of 9 years. So these are quite experienced clinicians. So this is the percentage, this graph shows a percentage of respondents reporting the type of interpreter use for more than 25%. So reporting that they used an interpreter in more than a quarter of consultations. And the first set of bars are about formal in-house interpreters, second, telephone interpreters, third, video, fourth set of bars is about using adults, family or friends, and the fifth, children under 16 years of age. As you can see, a lot of similarity between Australia, Canada and the US, with Ireland being a bit of an outlier. So face-to-face formal interpreters are used by more than half of consultations with refugees by about half of respondents in Australia, US, whereas in Canada it was a bit less, it was about a third, and 7% in Ireland. And the use of children and family members still occurred. It occurred across all countries, despite it being clear policy that it should not be used, that children in particular should not be used. It still occurred and was reported by these fairly committed practitioners, so reporting using it in at least a quarter of their patients. So we looked at what predicted more frequent interpreter use, so face-to-face or telephone or video use, and we found that really Ireland was a standout, as was not hard to determine. For face-to-face interpreters, older practitioners were more likely to use face-to-face interpreters. They were, so were practitioners who had been in practice for 10 or more years. There was no relationship between the type of practitioner, whether they were medical, nurse practitioner, nurses, or allied health providers, and there was no difference in terms of gender, which is a little bit surprising. The focus of the survey wasn't specifically about use of machine language interpreting, but we did ask a question about this, and this is the proportion of refugee patients with whom respondents reported using a computer written text to communicate in clinical context. So this included not just Google Translate, but a lot of it was Google Translate. And as you can see, that about just over a quarter said they didn't use it with anyone, and about another quarter said they used it with some patients, but not routinely, and the rest were distributed across the various categories. So there is some level of use by some practitioners, but at least more than half of them were reporting that they very infrequently used it. Remembering these are fairly experienced practitioners. Some of the barriers to interpreter use I thought I'd share with you. This is from the qualitative analysis, and I haven't got time to go into all of that, but respondents, and none of this will be news to any of you, I'm sure, respondents highlighted that finding a suitable interpreter and then including them in the consultation slowed them down significantly. And this was a consistent, repeated statement that people made, and therefore disrupts the goal of having relatively short consultations. And this is a quote: "It takes a lot of extra time, which is generally not built into the schedule, nor compensated." That was actually a US practitioner, but we got very similar comments across all the countries. And some doctors chose not to use a formal interpreter services and to rely on informal interpreting, other words, family members in particular, or machine translation instead. And this is an example of a quote: I've not used translation services recently as I found them difficult to use in the context of a busy surgery. Most of our Somali African patients bring a member of family with them. So this was a common refrain, and that where they brought a family member to interpret, the practitioners didn't try and talk them out of it. And I can understand that, because particularly using a telephone interpreter, it doubles approximately the amount of time that's involved. So over to you. Thank you.